These are screening assays. And some of these require high BSL labs that could look at a neutralization assay. And so as soon as we have that information, we will share that with you. But right now, we don't have a full picture of what immunity looks like. And until we do, we can't give a complete answer.
Thank you very much, Dr. Van Kerkhove and Dr. Ryan. Next question is coming from Michael Bosyurkiv, from contributor to CNN. Michael, please.
Thank you. Can you hear me?
Yes, please go ahead.
Okay, thanks for the question and the correct pronunciation of my name. Dr. Tedros, greetings to you. Again, I go back to the criticisms from the White House last week, especially in regards to the early actions by WHO. President Trump, among others, by the way, said that WHO was late to the game, so to speak, especially on the declaration of human-to-human transmission. I'm wondering if you could address that criticism, and very quickly, if you could also, what would be the financial gut punch, if you will, if funding from the biggest donor were withdrawn? I think the world needs to know how badly this would affect the organization at this crucial time. Thank you very much.
So thank you for that question. I will start, and perhaps Dr. Tedros and Mike want to supplement with this. So with regards to the human-to-human transmission question, so right from the start, from the first notification that we received on the 31st of December, given that this was a cluster of pneumonia, I'm a MERS specialist, so my background is in coronaviruses and in influenza. So immediately thought, given that it's a respiratory pathogen, that of course there may be human-to-human transmission. So initially, when we started to put together our technical guidance for our member states, we put guidance that focused on how this virus could be transmitted. And what we focused on was droplet and contact transmission, which is how respiratory pathogens are spread. We also, within our infection prevention and control guidance, put out a special provision for healthcare workers who are focused on conducting aerosol generating procedures, in which we put in place recommendations for airborne transmission. That guidance is still in effect. The guidance that we put up was on the 10th of January. It was the 10th and the 11th of January because there were 5 or 6 technical guidance materials that were actually put up on the web, which were open to everyone. We also shared this guidance package, which included surveillance guidance on how to find cases, laboratory guidance on how to detect cases, infection prevention and control, how to prevent infections, particularly in healthcare settings, because given our past experience with MERS and with SARS, we immediately thought that you could have transmission in healthcare facilities, you could have amplification events in healthcare facilities, and potential super spreading events. I did a press briefing on January 14th where I mentioned this. And in fact, that got quite a few headlines because I think saying that we may have super spreading events is something that we worry about as an organization, and we want to do everything that we can to prevent that from happening. We also put out a readiness checklist at the time for countries to say, how are we prepared to deal with a pathogen, a respiratory pathogen, and what systems do we need to put in place? And we lastly put out a disease commodity package, which listed all of the materials that one may need to detect cases, to care for cases, given that we didn't have a treatment, we still don't yet, but to put out how can we symptomatically treat individuals. And so very early on, suspected that there would be human-to-human transmission because it's a respiratory pathogen. And so that's why our guidance on the 10th and the 11th of January included information on how to protect people from getting infected, focusing on respiratory and droplet transmission.
And I just may add, in terms of official information to our member states, on January the 5th, WHO published an alert to all our member states on the epidemic platform that we have, and on the same day published public information on that on January the 5th. And very prudently on January the 7th, CDC established its incident management system in response to that, and subsequently put out a health advisory, I think, to all frontline public health and health staff in the US, which again, like Maria said, detailed the procedures for investigating cases, including droplet spread precautions and the mechanisms for investigating and asking all physicians and frontline public health workers to report any cases meeting the preliminary case definition. So from that perspective, the information was shared, and very appropriate actions were taken in the United States in response to that alert.
Thank you very much. Hope this answers the question. We go now to Kimberly from Time. Kimberly, can you hear us? We will try one more time. Kimberly from Time.
I'm here. Thank you for taking my call. Apologies for my inept action with Zoom. I wanted to ask whether China has yet given the WHO the DNA samples from the original outbreak, as well as explained on what date it concluded that there was indeed human-to-human transmission. And also, has it done enough in terms of virus sharing as of today? And what assurances has it given you that it will share in the future?
I can start. And so I believe, I have to go back at the timeline, but I believe there were some suggestions of human-to-human transmission in mid-January. And with regards to virus sharing, I know your question was about China, but in terms of the development of diagnostics, the development of therapeutics and vaccines, it's really imperative that viruses are shared by all countries that have access to these samples. And given the fact that it has transmitted to a number of countries, we support the sharing of these samples to other labs so that those diagnostics, those vaccines, those therapeutics can be developed. The sequence itself of the virus was shared on the 12th, if I remember correctly. And because that happened, we had PCR assays that were rapidly developed and shared globally. I believe we posted the first PCR assay on our website on the 14th of January. And so because of that, a lot of labs were able to develop PCR assays, and so detection globally could happen very, very quickly.
Thank you very much. Next question is Peng Hui, People's Daily. Can you hear us?
Yes, can you hear me?
Yes, please go ahead.
Oh, thank you for taking my question. There is a positive signal about Europe, the DG said last week. So how do you assess the current situation in Europe? Do you expect the turning point coming in 1 or 2 weeks for most European countries?
Obviously, we all dearly hope that is the case, and we've certainly seen a stabilization in a number of countries in the direction of travel of the epidemic curve, and the intensity of increase has stabilized. And some countries have actually begun to see a pretty consistent drop, first in the number of hospital admissions, but then we should start to see that follow through. Deaths take a little bit longer to drop because many people are in hospital already, and some unfortunately may die. So we look at the number of confirmed cases and we look at the number of hospitalizations as the first indicator that things may be stabilizing. And we're certainly seeing that, and it's with great credit to people all over the world, and particularly in some badly affected European countries, that they've stuck with the task of physical distancing and stay-at-home orders, and that's taken the pressure out of the epidemic. But by no means does that mean that it's over. Now is the time for vigilance. Now is the time to double down. Now is the time to be very, very careful. And that does not mean that countries cannot begin to create an exit strategy. It doesn't mean that countries shouldn't be actively planning to do that. But as the Director General said, there are, in that sense, there are things that need to be done. You can't replace lockdown with nothing. You must replace lockdown with a very deeply educated, committed empowered and engaged community. We are going to have to change our behaviours for the foreseeable future. And we've seen a huge embracement of that by people. And in the vast majority of cases, that has not needed to be enforced. The vast majority of citizens are doing what they can for themselves and to protect others. But we are going to have those adapted behaviours in terms of personal hygiene, physical distancing, being careful for a long time. So the base of moving out of lockdown is communities on the alert, communities aware of the risks and communities taking action, continuing to take action to protect themselves and others. That needs to be backed up with a way of finding the virus. At the moment, everybody is suffering because everyone has to be separated. That's because countries don't know exactly where the virus is. The only way to get out of this is to find the virus. The only way we find the virus is to identify those people who may be infected and test and isolate, find contacts and quarantine contacts. And that is, in a sense, community empowerment, community involvement, and public health intervention through the use of case finding, isolation, contact and quarantine is the alternative to having lockdown and having a health system that's capable of absorbing any increase in cases. We need to continue that strength in the health system. It's incredible how health systems have adapted and how hospitals have expanded, how they've done amazing things, absolutely incredible things over the last number of months. And they have saved many, many lives. But we're going to have to sustain that capacity. And health workers are going to have to continue to have protective equipment, and we're going to have to continue to have intensive care beds on standby, because as we come out of these lockdown situations, we may see a jump back up in cases, and we don't want to lurch from lockdown to nothing to lockdown to nothing. We need to have a much more stable exit strategy that allows us to move carefully and persistently away from lockdown. And the only way to do that is to have fully empowered communities and a fully activated public health architecture and a strengthened health system.
Small addition to that to say it's really important that the lifting of these measures doesn't happen all at once all over Europe. And we completely understand we're in the same situation, the desire to want to release those and get people back to work and kids back to school and all of that. But it's really important that it's not done all at once. Because if the systems are not in place that has just been outlined, if the systems to identify where the virus is, to isolate cases, to find the contacts, to treat the cases, to have the beds free to actually care for patients, then you're going to be overwhelmed again. So what could happen is if they're lifted in certain strategic areas, maybe where there's lower incidence, and if that can happen slowly, then the system can divert where it needs to go to be able to quickly identify those cases, while other parts of the country may still have those restrictive measures in place. But it does have to happen slowly. It does have to happen in a very controlled manner, and it is important that the community understands this, because it may be a little bit longer that you have to remain at home, or you have to work from home, or schools may need to be closed. But again, this is temporary. I know it seems like a long time now, but it is temporary. So not lifting all at once is very critical so that we can get people back to work, get these economies going back again as quickly as possible.
Thank you very much. Now we will go to Morocco. Mr. Mohamed Ashari from Morocco Media News. Mr. Mohamed, can you hear us? We will try to establish the line with Mohamed from Morocco. Can you hear us?
Yes, I do.
Please go ahead.
Can you hear me? Yes?
Yes, we can hear you very well. Please go ahead.
Okay, thank you very much. Thank you very much for giving me a chance to say my questions. Actually, I'm talking especially about Morocco. Please, could you tell us how fast we going, towards this pandemic, and how if we slow or fast towards this pandemic, and also to stop and to slow the cases, especially I'm talking about Morocco as an example. Thank you very much.
Thank you very much, Mohamed. The line was not the best, but we understood that the question is about situation in Morocco. So I will see if Dr. Ryan could say something about it.
I think Morocco has approximately 1,600 cases at the moment, and I think the numbers are increasing of the order of 70 to 90 per day. So the doubling time in Morocco is actually quite long, and in that sense, Morocco has the opportunity to keep it that way. There have been 76 deaths, unfortunately. So mortality is reasonably low. The epidemic curve is relatively flat, but that can change at any time. We've seen this in country after country. Countries go along with a small number of cases, and then it reaches a certain point, and that curve takes off. So it's really important, and many countries in the Eastern Mediterranean and North Africa have done a good job in doing that. But it does require to have extensive testing and broaden testing out. Actively looking for cases and dealing with all of the other strategic issues that other countries do. But in principle, Morocco is in a strong place to continue control measures and also be in a strong place to be able to lift any restrictive measures, as long as Maria has said that that's done gradually, as long as that's done with great care, and as long as the other public health and community measures are in place. But I'm sorry, I don't have a detailed set of data for Morocco in my head, but if my memory serves me, that is where Morocco is epidemiologically at the moment.
Thank you very much. Hope this answers the question from Morocco. Next question is from Devex, from Sarah Jerving.
Thank you. I'm wondering what is the appropriate time frame for someone to isolate if they think they might have been exposed. There seems to be this belief that 14 days is appropriate, but since the incubation period can be up to 14 days, so then if someone is not showing symptoms after 14 days but does have the virus and doesn't have access to a test, how long after that can a person have the illness and be contagious? And then in terms of the reactivation in people, based on your previous response, is it possible for the virus to be latent in someone, or are we talking about reinfection?
Thank you for these questions. So yes, what we recommend for somebody who is exposed to an infected person is that they be followed, that they be quarantined for 14 days. Most people who are infected with COVID-19 will develop symptoms within 5 days. That's the median time, 5 to 6 days. But it goes up to 14 days. So 14 days is a good marker. For individuals who are infected, your question was how long can they be contagious? And that's the right question, because when we actually test people who are infected with COVID-19, they have this molecular test, a PCR test, and they can be PCR positive for weeks. But that doesn't actually mean that they're contagious for weeks. So what the PCR does is it measures fragments of the virus, parts of DNA of the COVID-19 virus that is detectable through this molecular test. But it doesn't actually mean that you're contagious for that long. What we've seen from some preliminary studies, and I'm referring to a study from Germany, is among some mild patients, I believe it was 8 or 9 mild patients, that they could find live virus for 8 or 9 days after symptom onset. What we need is much more data from countries to actually be able to say how long is someone contagious. And so right now what we have are these PCR tests which suggest that people with mild disease can be PCR positive for 2 to 3 weeks. What we need to understand is out 2 to 3 weeks, are those people still contagious? And so again, this is another example where we don't have the full picture, but there's a lot of studies that are underway to give us those answers. And so we hope to be able to get back to you with more details on that as soon as they're available. PCR tests
on the issue of reactivation and latent infection,
what we need to understand is
there are many situations in viral infection where someone doesn't clear the virus entirely from their system. It can happen in the case of immunocompromised people who are sick for other reasons, and then the virus can come back and attack the person again, and that's sort of seen as reactivation. It's not that it's usually that the virus was never properly cleared. There are other situations where someone clears the virus but develops a second secondary infection, a secondary bacterial infection, often in influenza, for example, it's not the influenza infection that causes the problem. It's very often the secondary bacterial pneumonia. The damage to the lungs and the inflammation creates, unfortunately, an opportunity for bacteria that are normally non-pathogenic, they're all over the place, but can actually exploit the fact that the lungs are weakened. And you end up then with a very high fever again and very sick, but you're actually not sick with the virus, now you're sick with the bacterial infection. So there are many reasons why we might see reactivation of infection, either with the same infection or with another infectious agent. The issue of long-term, I think, transmission has been dealt with by Maria. There will always exploit the fact that in health be exceptions. There will always be individuals who may transmit for longer. There may be individuals whose incubation period may be for longer. It may happen. There are outliers in every walk of life. We all know people who are given a year to live because of a cancer diagnosis and they live for 10 years. That doesn't mean that everyone with that diagnosis lived for 10 years. It means one person has lived for very much longer, but on average, this is how long people survive. And I think we need to look at that. These are averages, and then we look at the range around the average, and we try to explain that this is likely where the longest or the shortest incubation periods are in reality. But there will always be a chance of an outlier. And I always say we need to study the outliers. We need to study those who transmit for longer. We need to study those who don't clear the infection properly, because these are very significant events. But we also have to be able to make good public health policy, and we have to try and make the best possible estimates of what is a reasonable incubation period that incorporates the vast majority of people, and reasonable transmission periods that incorporate the vast majority of people, and at the same time look at outliers, examine them, why they're occurring. And that is the work of science, and in the end, you've got to translate science into policy. You've got to translate all of that data into a rational policy that can be implemented for public good.
Our policy actually is, it may be helpful. And this is based on the science that we have. So what the WHO recommendations are is for someone who tests positive for COVID-19 with a PCR test, what we recommend is to be released from either hospital or from home isolation is that their symptoms resolve and they have 2 negative PCR tests 24 hours apart. Now, we realize that that may be difficult in many situations where lab testing may be challenged for one reason or another. So in situations where tests are not available, if you have someone that's home that's a suspect case, that's a probable case and couldn't get tested, what we recommend right now is that those individuals are in home isolation if they can't be isolated in a medical facility until their symptoms resolve, plus an additional 14 days. Now, what we're trying to do right now is look at that 14-day extra period to see if that's something that can be reduced based on available data.
Thank you very much. We have time for maybe another 1 or 2 questions. So let's go to Guatemala now, to Grecia Ortiz from Diario La Hora. Grecia, can you hear us?
Yes, this is a question for Dr. Tedros. Many countries make the use of masks mandatory, including Guatemala. But what other measures must accompany their use, and what are the measures that you, as the WHO, consider vital or important?
WHO obviously advises the use of medical and N95 respirator masks in a healthcare environment, and I think our guidance is quite clear on that, and we want to see that type of material reserved for use in that environment. However, there's been a very healthy global debate around the use of masks more broadly, or face coverings more broadly at societal level. WHO has been clear that there is no specific evidence to suggest that a mask may protect you from infection. Equally, a mask may provide protection for others if you happen to be symptomatic and coughing. It might stop you contaminating somebody else. There are a number of issues around the broader use of masks. One, in that it may divert mask use from the healthcare setting, and that's something that just cannot happen. There are issues around wearing those face coverings and disinfecting those face coverings and disposing of those face coverings or masks, and the fact that putting on and off those masks involves people often touching their face as well, and therefore it cannot be done outside the context of very clean hands and proper personal hygiene. And also masks are not an alternative to lockdown. And we've said this publicly again and again. WHO will support countries who wish to implement a more broad-based strategy of mask wearing or face covering wearing on a broader basis, as long as it's part of a comprehensive strategy, as long as it's linked to the things we said before: community education, personal hygiene, a strategy to find, test and isolate cases. If mask use is added to that, then I think that WHO can see the value. But if mask use is used as an alternative to those public health strategies, if it's used as a reason not to do those other things, then we believe that is the kind of policy that's counterproductive. So we see mask use in the broader context of a comprehensive strategy, and in that sense will support member states who wish to introduce that, as long as it does not take masks out of the healthcare environment, and people know how to wear them, know how to dispose of them, and are doing all the other things that they need to do. Maria?
Just to add, with the comprehensive strategy that Mike just mentioned, it includes also physical distancing, it includes hand hygiene, it includes respiratory etiquette, it includes staying home if you're unwell, it includes cases being isolated, confirmed cases being isolated, it includes contacts being in quarantine, and it includes following, the directives of the national governments if there are stay-at-home orders in place. And of course, overall, having an empowered community to know what they can do to protect themselves and their families. So as Mike has said, it's part of a comprehensive approach. It cannot be used alone. But we support governments in making these decisions. And in our recent updated guidance, we've put some considerations that they may take into account when making these decisions. For example, if physical distancing is not possible in certain communities or certain populations, perhaps the use of a face covering or a non-medical mask may be useful there. And so we, like Mike says, we support these decisions being made, but as part of a comprehensive approach.
And if I could just supplement, one of the consequences we really don't want to see happen as lockdowns are eased, there is huge pressure on people to go back to work, to go back to school, to participate in daily life. I don't want to be the person